Well, hello, I'm Wendy Burton. I'm a GP from Brisbane, and I'm here with my colleague, Dr. Pam Douglas, who's also a GP at Brisbane, and we're going to talk today about tongue tie. So Pam, oh my goodness, it's early 2019. Tongue tie has been a thing, is a thing, it's a real thing. It's been known about for multiple generations. But here we are, it's 2019, and tongue tie, is it underdiagnosed? Is it overdiagnosed? Are we not recognising it? Are we calling normal abnormal? Pam, help. So Pam, for me, the classic would be perhaps reviewing a new mother with her baby at perhaps that 5 to 10 day mark, and she's concerned the breasts are hurting, there's some pain with the initiation of the breastfeeding, she's worried that her baby's not getting enough milk, the baby's crying, she's not sure about the weight gain, and somebody has already placed in her mind that perhaps this child has a tongue tie, or has out and out said to her that they have a tongue tie. When I think tongue tie, I think about that membrane of tissue underneath the tongue that attaches the tongue to the floor of the mouth. And I think if that is too thick or too long, then the tongue can't actually move out past the lips. And that it'll tether, it'll start to take a little heart shape, and that might give problems for sweeping debris off teeth once they've established, not now newborns, or might give articulation problems with speech, so the sounds where we need to move the tongue out, and licking ice creams and important things.
You can't go through life without being able to lick an ice cream.
I know. So I am naturally concerned if there is indeed tethering of the tongue that limits its movement in a way that would compromise that child, either with breastfeeding, with dental care, with speech, or with the pleasures of life such as licking ice cream. How can I look at that child, examine that child? How can I help to know if that child actually has a tongue tie that needs to be fixed or treated?
Yes, okay. So I suppose the place to start with this newborn would be an Oromotor assessment.
Okay, how do I do that?
It's not the place to end. It's
Okay.
the beginning in terms of an assessment. So it would be part of your newborn check. But once you come to the face, you've looked at the skull, looking for asymmetries, the face, checking for asymmetries. Happy that there's no abnormalities of the face and the skull. So then with parental consent and with gloves on your hands, you'd commence an oral examination. So I place the baby on a mattress on the examination couch, so a nappy change mattress, and I like to examine the baby with the baby facing me, so the head's away from me and the feet towards me, and I'll ask one of the parents to stand beside us, beside the baby, and actually hold that little one's head just over the ears, not lifting the head, but just securing the baby's head so that the little one can't move from side to side while I'm doing this check, and possibly a little bit of extension so I can see I have my headlight on. And so then we can start by lifting up the upper lip, and this is where we'll demonstrate to parents that upper lip is actually very flexible. It invariably is, actually. And what we'll see is a labial frenulum in all its glorious anatomic diversity. So sometimes it will be fine and attached quite high. At other times you'll see the attachment may even be right down to the edge of the gum, or appear to go into the almost towards the undersurface of the gum. But these are actually all normal anatomic diversity of a labial frenulum. And the lip will always be able to be moved up flexibly, and you may see a little blanching. If you wish to look for that, it's not actually helpful to look for it, but you may see a little blanching because that's inevitably going to happen when you put tissues under tension. You may even look for some buccal mucosa folding down from the upper lip onto the upper gum. Actually, there's no real advantage in looking for it because the concept of a buccal tie is irrelevant. It is not a meaningful diagnosis. There'll be, again, anatomic variations in terms of that mucosa. So then you may sweep down to have a look at the inside of the cheek, so the buccal mucosa on either side, and I must admit at this point I'm checking the gums as well, looking for something like thrush or candida, just doing a careful check while we're there for any infection. You may also, at this point in time, use a tongue depressor and have a look for a cleft palate. So checking the palate, noting the shape of the palate, but again, the palate is extraordinarily anatomically diverse and not going to, in itself, be a cause of nipple pain and breastfeeding failure.
Because sometimes, is it the high arch palates that women are told that this is?
Women are certainly told that they'll see a high arch, a high palate associated with a tongue tie, and in fact they'll be told with a recessive chin as well.
Right.
And there are theories around anatomic developments there that are actually not useful or based in any real developmental anatomy, actually. We've had a look at the palate, then we may come down to run our forefinger, the pad of our forefinger along that baby's lower gum to look for the lateralization reflex of the tongue. And you'll notice that the tongue is following your finger in all sorts of ways. There will be perhaps some humping movements of the tongue, a little bit of pulling back, certainly some lateralization. And these variations on the surface of the tongue and the ways in which the tongue shapes itself, it's like this muscular hydrostat. So it's capable of the intrinsic muscles of the tongue are capable of extraordinary plasticity, but they're not going to tell us much about the tongue's capacity to move. We lift the tongue then, with the two forefingers and have a look at the lingual frenulum at that point, paying attention to its insertion points. And in fact, again, the lingual frenulum, as you'd expect, is extraordinarily anatomically diverse.
Right.
And you may even feel as though you're not seeing much of a frenulum. It may be quite flat with the surface of the tongue.
Right.
Or you may see variations of an anterior membrane that run under the tongue. And in fact, I use a variation of the Griffiths classification system. I'll just say 25% anterior membrane, referring to the approximate distance it attaches along underneath the tongue, or 50% anterior membrane.
So a 25% would be that from the base of the tongue to the tip of the tongue, the first 25% is attached, or the first 50%. Yeah. Is there a point there? Is there a number? Can I have a number, please, Pam? At which case I say, oh, that one needs to be snipped, or that one doesn't, or is it way more complicated than that?
It is really more complicated than that. I think the truth is, if we have a 100% membrane or something close to the tip of the tongue,
yes,
it's a simple matter to perform a scissors phrenotomy. But you'll see that I want to talk to you about tongue function and how we can't make sense of tongue structure without really looking at tongue functionality. So can I go back to the lingual frenulum?
Please do.
because the truth is that these anterior membranes are really very common, and not impacting on the function of the tongue at all. And it's possible to have an anterior membrane that is extending, really 70%, 80%, and to have it's wonderful, stretchy, excellent tongue mobility.
Okay.
So I wouldn't call this a tongue tie, because the tongue isn't being tied by this tissue.
Is there any way in that examination on the couch I can demonstrate that the tongue is tied, or is that in interfering with breastfeeding, or is that an observation of the feed itself?
It's going to be a clinical judgment
Mm-hmm.
that's made out of multiple observations in your
Mm-hmm.
clinical examination.
Mm-hmm.
And this is how we function as GPs, and indeed clinicians more
Mm-hmm.
broadly, all the time.
Sure.
We synthesize
Mm-hmm.
multiple pieces of information to then offer a recommendation to our parents. So in fact, the search for a simplistic solution here.
I want a simple.
A number. It's actually not the way we work as wise clinicians.
Okay.
We really need to be looking at multiple pieces of information.
It needs
So-
like medicine.
Yeah, so I want
Mhm.
to continue on with my assessment,
Sorry.
if I can.
Please
And so we've had a good look at that lingual frenulum. We might also, at that point, insert our gloved finger, perhaps the little finger or the forefinger, gently place that pad up against the hard palate and feel the little ones suck. And sometimes I'll even draw the lower lip down and have a look at what the tongue is doing
Mhm.
as that little one is sucking. But the truth is that very often our babies don't wish to perform in that way. They don't like to suck on a glove. And what happens when there's a finger in a baby's mouth is entirely different to what happens when that baby's breastfeeding.
Right.
So again, although these are indicative and it's worth doing this oromotor assessment, in fact, one of the great contributions of this focus on oral connective tissues has been the raised awareness around the importance of doing an oromotor
Mhm.
assessment. But we have to understand that all of this can only make sense in context of multiple other pieces of information. I didn't mention, but you'd also just note the shape of that little baby's chin
Mhm.
as well. Now you'll see that this is a kind of working clinician's oromotor assessment. In fact, our clinical breastfeeding support people are being asked to use a whole range of oromotor assessment tools, none of which I would argue are particularly helpful beyond this kind of pragmatic, a professional but I guess what I'm wanting to say is that it's pragmatic and it's going to give us some useful information. A lot of the kind of details in an oromotor assessment that breastfeeding support professionals are being asked to do at the moment are actually not useful and will just heighten anxiety for both that professional and for the family.
Mhm.
So there's our oromotor assessment.
Okay, so we've done that.
Yeah.
Mhm.
Now, of course, this is where we do need to move to a breastfeeding assessment.
Mhm.